Hi, I don't know if anyone can hear me. If you can you let me know somehow, please? Perfect. Excellent. So I think there are 3 of you currently attending. I'm going to make a start, and then people can kind of join as they want to, if they want to. So this is kind of a session on, I guess, medical on-calls as an F1. It's a session that I kind of wish I attended myself when I first started, because I didn't really know what to expect, didn't know what kind of calls I was going to get, and didn't really know how to handle getting lots of bleeps at the same time. So in this session, I'm going to cover these 8 topics. So what I actually wanted to start with is just kind of a learning point on prioritization. So I'm going to try and be a bit interactive. I don't know if it will work, and if you guys can help me out, that would be great. But what I'd like you to do, first of all, is just have a look at these 8 topics. Imagine you get all 8 bleeps at once, and all you know is the title of the bleep. I know this isn't how it happens in real life, but imagine that you have these 8 scenarios. This is all you know, and think about maybe how you would prioritize them. And what I'm going to do is then go through 8 different scenarios with a bit more detail, and then come back at the end and revisit this and see how you would prioritize them, knowing what you know. And that might help you kind of work out what information you would like to gather in order to be able to help you prioritize, if that makes sense. So I'll just give you a minute to kind of have a look at those, see how you would prioritize them based on no information, and see if anyone else joins as well. I'm not going to ask you to tell me what your priorities are. This is just kind of for you to reflect on the difference between the beginning and end. So don't worry about coming up with an answer. I'm not going to pick on anyone, and there isn't really a right answer. It's just kind of an interesting learning point. Okay, that's probably enough time sitting in silence by yourself in a room. It is enough for me anyway. So I'm going to go through these 8 scenarios. They're not in any particular order. It would be great if you guys can help me out with some interactivity. We'll see how that goes. I know what it's like sitting on Teams and pretending you're not there. So if that's the case, then that's fine. I'll just talk through it, but it would be great if I could get some help. So the first scenario is chest pain. So what I would really like is if you guys can throw out there, you get a bleep, the nurse says, I've got a patient with chest pain. What else would you like to know from in that scenario? What are you going to ask while you're still on the phone? Yeah, so I'm seeing a few people saying news and what they're scoring for. Anything else? Yeah, perfect. So what they came in for. So I'll tell you, this patient is a 59-year-old man. He was admitted to hospital with an upper GI bleed. His OBS are on the screen. I won't read them out, but you guys can have a look at that, see what you make of it. And he's got a past medical history of peripheral vascular disease, high cholesterol, hypertension, and chronic back pain. So this is kind of me just creating mini scenarios. So then you're going to go and see the patient. What's the first thing you're going to do? Yeah, perfect. Great. You guys are going to, smash it. The classic OSCE answer, first thing you're going to do is an A to E. So you go and do your A to E for this gentleman, and this is kind of a brief overview of what you find. So his airway is patent, you're not worried about that. His respiratory rate is slightly high, but his chest is clear and his saturations are pretty okay. In terms of his circulation, he's got a cannula in situ, he's got ongoing chest pain, he's a bit tachycardic and a bit hypertensive. His GCS is 15 and his pupils are reactive, and glucose is normal. He's afebrile, but his skin's quite clammy. And then I'll just tell you a little bit more about this gentleman. So this is what he tells you when you review him. So he's got central crushing chest pain radiating to his left arm. He's feeling sweaty, clammy. This came on quite suddenly and it's associated with nausea. What are you guys thinking at this point? Yeah, perfect. So someone said ACS. So yeah, MI, all the same thing. So I realize this is quite an obvious history. I think I've tried to make all of my histories quite obvious because I think you spend a lot of time at medical school learning how to diagnose things. And in my experience anyway, not a whole lot of time doing the acute management. So you might learn about an MI and then you'll learn the secondary prevention, but actually what you do when you first walk into the ward and see someone with chest pain, I found really difficult. So spot on with the diagnosis. Please bear with me. I know they're all quite straightforward. I don't know how well you can see this. I don't know how big it is on your screen because it's tiny on mine, but does anyone have any thoughts on this ECG? Yeah, so I've got one person saying anterolateral STEMI. Anyone else? Yeah, great. Good. So, so in this ECG, you've got some ST elevation in V1 to V6, and also some in leads 1 and AVL. And then there's some reciprocal ST depression in lead 3 and AVF. So like you said, your working diagnosis at this point is STEMI, anterior STEMI. So that's all great. That's medical school, tick. You've done final year. You have become a doctor. You knew all of this because that's how you've got here. What are you going to do? And this isn't like long term. This isn't even let's get them a PCI. Like this is you as your first day on an F1 and you go to a ward and someone has this. What are you going to do? Just going to wait for a few more answers. Loving the ones that are there at the moment. Yeah, exactly. So what are you going to do as the F1, as the first person there? You are going to call the med reg probably before you do anything else. You're going to put a second cannula in, and while you're doing that, you're going to take some bloods, including the trop, which someone said, and then you're going to do your initial management, so morphine, oxygen, although you don't need that here because SATs are okay. You're going to do GTN and your 300 milligrams of aspirin and 300 milligrams of clopidogrel. In this situation, you don't need an ABG because SATs are normal and it might actually slow you down with doing other things. If SATs were abnormal, then you probably would want an ABG. That's kind of the story of life, really. If your SATs are low, you probably need an ABG. So that's your management acutely. And then beyond that, day 1 of F1, day 360, which is where I am of F1, that's all anyone's expecting from you. If you can do more than that, great. But if you can't, basically, if you can do an assessment and call the med reg, you're in a pretty good position. Anyone have any questions about this first scenario? Cool. I'm going to assume that no questions means no one has any questions and move on to the second scenario. So the second scenario is shortness of breath. So again, we're just going to do the same thing. Nurse calls you, says, "Doc, a patient's is short of breath. He's struggling to breathe." Sorry, she's struggling to breathe. She's a woman. What do you want to know? You're going to say the same things. I might speed this along a bit. So you're going to say, "News, please," and what were they admitted with, and give me a little overview of the patient. And this is what they're going to tell you. So it's a 40-year-old woman with new onset shortness of breath. She was admitted to hospital with biliary colic. Her OBS are in front of you. Are you worried about her based on her observations here? Good. Yeah, me too. So you're going to go and see her. You're going to tell me the OSCE answer of A to E. I'm not going to patronize you by making you say it every time. You kind of nailed that one on the first go. So this is your A to E. And I want you guys to, I'll just read you through it. And then if you can tell me what you're thinking. So airway's fine. She's got tachypnea, chest is clear, normal air entry. SATs are still low. She had a chest x-ray at 5:30 and that was fine. So that might kind of help you on your way to a diagnosis. We've sent an ABG and obviously I'm going to show you that on the next slide. She's a bit tachycardic, a bit hypotensive. She's got a cannula and her ECG shows sinus tachycardia. GCS is 15, her pupils are reactive, glucose is fine, and she's afebrile. And I don't know what it stands for. It means nothing, no abnormality detected, maybe. It basically means there's nothing abnormal. Yeah, thanks. And then you get to the exposure and you do everything properly and you actually expose her and you find that she's got some swelling in her right calf. What are you guys thinking? Yeah, good thoughts. So then you take a little focused history. This shortness of breath is acute. She has some chest pain on inspiration, and she's also taking the combined oral contraceptive pill. We're probably thinking PE, but let's not get too ahead of ourselves because we've got to look at an ABG first. So, does anyone want to have a go at interpreting this ABG? Yep, absolutely. So we've got a respiratory alkalosis that's not compensated. Anything else that you would kind of summarize this as? There's kind of two ways to summarize an ABG, and you've got one of them. I just want the other one. Yeah, perfect. So we've got type 1 respiratory failure and mild respiratory alkalosis with no metabolic compensation, which is exactly what you said. So this is, again, in keeping with what you all said, which is PE. So this is our working diagnosis. So we've done that, bish, bash, bosh, fine. What are we going to do? So this, what you guys are saying, MedReg is great. CTPA is probably unlikely to be your call because you'll probably want the MedReg to review them first. They had a chest x-ray not too long ago, so, and we think it's PE, so it's probably not indicated because if we're going to be doing a CTPA anyway, that will tell us everything that a chest x-ray would. I like what you said about the world score. We could calculate it. We probably would know that it's going to be high. And definitely we're going to run it past the senior, definitely going to be calling the MedReg. Is there anything that you would do in your A to E? So I know I've only done the kind of findings. What about the interventions on your A to E? Yeah, so we're going to be putting her on oxygen. She's got SATs of 88%. She's got IV access already, but we're going to use that IV access and because she's also hypotensive. So we're going to give her some fluids, we're going to give her some oxygen. We're going to call the MedReg, and we're probably going to wait for them to get here. But if we're twiddling our thumbs, then we'll probably request a CTPA. All of the things that you guys have said, the D-dimer, the well score, anticoag, that's all probably right. Except that you're probably not going to do that stuff. So, like, this is kind of what I mean by it's quite hard to judge on day one, like, what's actually expected of you. So they are going to end up anticoagulated. You'll probably know how long for, and you'll probably know that better than most of the consultants that hang around the hospital. because you've learnt it and they can't remember it. But what you're going to do is you're going to A to E, you're going to chuck them on some oxygen, you're going to give them some fluids, you're going to call your med reg, and you're going to say, I think this person's having a PE. This is my findings from my A to E. And they're going to take it from there. They'll probably send you off to do some other jobs, or they might ask you to stay and help them and do some documentation. But realistically, you're not going to be prescribing the anticoag by yourself. You're not going to be requesting the CTPA by yourself. You're going to be doing the assessment, calling for help, and then doing what you're told. So I think that for me would have been really helpful to know, because I was really stressed about what to do in all of these situations. And basically the answer is always A to E, do what you can, call for help. Unless you don't need to, which we might come on to. So that's the shortness of breath one. Anyone got any questions? If not, I'm going to try and fly through because we've only done 2 out of the 8. Though some of them are quicker. So the next one, nurse is on the phone. Doc, my patient's had a fall. What would you like to know? Yep, great question. All good questions. Is this stuff that you're going to ask on the phone, or what would you want to know on the phone? All of this stuff is definitely what we're going to find maybe on this side of the slide. Yeah, great. So same old situation. Let's get the OBS. Let's find out a bit about the patient, because it might actually change how urgently you go and see the patient. So this is a 25-year-old man. He's had a fall. He was admitted to hospital with a Crohn's flare. His OBS are normal, news 0. He's got past medical history of Crohn's, nothing else. They kind of, you go and see them, or maybe you ask a few more questions on the phone. They tell you that the airway's patent, your rest rate is 17, sats are 99%, chest sounds clear, cardiovascularly looks well, normal cap refill, GCS 15. You do a little neuro exam, pupils are equal and reacted to light, and he's afebrile and he has no signs of bony injury. And a little history is that he was walking to the bathroom and he tripped over the edge of the flab trolley. He didn't have any shortness of breath, chest pain, palpitations, dizziness, loss of consciousness, head injury, all fine. And he's not in any pain at the moment. So what do you think of this guy? Are you worried about him? Good. Yeah. So this, to me, is much less worrying than our previous 2 patients. So I wanted to just go through the CT head guidelines, which I'm sure you guys probably know better than I do, but I've got the slides in front of me. So what do you think of, what are the guidelines for doing a CT head within an hour? Just 1 or 2 things, and then I'll put them on the screen and we'll fly through it. Yeah, so it's actually GCS less than 12 or less than 15 if it's a bit later. I won't read them all out. They're on the screen. They're quite specific, nice guidelines, so you can just look it up. Like, that's the other thing that you forget. You can just look up whatever you don't know while you're walking to the ward. Quick Google, jump on Geeky Medics. You like, Google will save you. And then these are the guidelines within 8 hours. So I've just put these on here for reference, really, but like I said, don't memorize them. Google them on your way. And I jumped ahead there, but your working diagnosis here is mechanical fall with no head injury. So what are you going to do for this guy? I think you've sort of said already. So you're not that worried. You're going to monitor him, continue some obs. You're going to do a falls review, which I think I sort of already summarized, but you're going to have a feel of his shoulders and his hips and his femur. Make sure that there's no pain on palpation, no visible deformities. You're going to have a feel of the head as well and just check that there's no, lumps and bumps on the head. So in this particular case, you just need to document that you've reviewed them and, like you said, maybe increase some observations. But honestly, you'll be so busy that if you don't hear about this guy again, you won't think about this guy again. Let's power through. I think we're almost halfway and we're about halfway through the time. So any questions about the fall? Good, right. So next one is confusion. So you've got someone on the phone, they're saying, I've got a confused patient. What do you want to know? Probably their observations, probably a little bit about why they're in hospital. So this is an 88-year-old lady who's admitted with acopia. Acopia is a word that's used a lot. I'd never heard it before. It just means not coping. I don't even know if it's a real word or if it's one of those like medicisms, but not coping at home. She's got past medical history of Alzheimer's disease and also previous bilateral PEs and trigeminal neuralgia. Her obs are on the screen. So again, news one, I guess, for confusion. You go and see her, you do your A to E, and she looks pretty well. So you can have a quick scan over that. But basically, GCS is 14 because of confusion, and otherwise everything is normal. So you try and get a bit of a history about this confusion from the nurse, and the nurse tells you that this lady is medically fit. She's awaiting a placement at care home. She's had confusion since she was admitted to hospital. She's very agitated. She's shouting. She's keeping all your other patients awake. But she's actually at her baseline. So these symptoms are chronic, and a confusion screen has been done by the regular day team and is negative. So this is her baseline. So are you worried about her? What's your working diagnosis? So I'd actually say that this isn't really a delirium picture because this is her baseline. So delirium, I would probably say, is like an acute change in mental state from her baseline. And what they're telling you is that this is her chronically. So my working diagnosis here is dementia with BPSD, which is behavioural and psychological symptoms of dementia. You'll get calls like this more often than you would think, because nurses won't want their patients shouting all night. They won't want everyone else in the bay being awake. And you'll get calls saying, please, can you prescribe some lorazepam? My patient is agitated. So this one I've put in here because they don't really tell you what you're supposed to do in this situation. And it happens quite a lot. So what would you do? You're asking me questions off the top of my head. Confusion screen would basically be an infection screen, so probably chest x-ray, have a look in the ears, urine dip. And then you've got things like TFTs, calcium. We're actually going to come on to causes of delirium, so maybe that will answer that, but you're basically trying to rule out strange causes of delirium that you might not have thought of. I can't remember them all, to be honest, off the top of my head, and that is something that I would look up if I needed to do one. Thank you. Thanks, that's really helpful. So with this lady, what you're going to do is you're going to review her. You're going to go there and kind of do your own little mini confusion screen. You're going to check that there's no new fever, that they're not in pain, that there's no obvious change in the environment, nothing that would obviously be distressing them or causing an acute delirium, which we will come on to in a bit. Once you've kind of ruled out an acute cause, then you're going to assess the risk of harm to self or others. So if they're kind of throwing themselves out of bed and it's taking 3 nurses to keep them in bed, and they're very aggressive and they're lashing out and they're potentially going to hurt someone or themselves, then that would be probably quite a different situation to a little old lady who's lying in bed, distressed, shouting, but not really harming anyone, including herself. So this is kind of quite subjective, and the first few times I think it would be absolutely appropriate to call the med reg and say, look, they're asking me for this. I don't know whether it's appropriate to prescribe that or not. By the time you get to the end of F1, you might feel a bit more confident in making that decision yourself, and it might be appropriate to prescribe a small dose of lorazepam as a one-off. It might not. So I would say that in this situation, go and assess them, see what you think, then call the med reg. Med reg probably doesn't need to review them on this occasion. They can probably rely quite well on your assessment. So just do your assessment as well as you can. That's kind of that for this. It comes up a lot. You will get a lot of calls asking for sedation. You'll get a lot of calls asking for sleeping tablets. Just use your common sense, I guess, and see how necessary you feel it is. Okay, next one is, does anyone have any questions about that? Because it is a bit more subjective than some of the other kind of cases. Cool. Right. The next case is low GCS. So your nurse rings you, low GCS. You're going to get some OBS, you're going to get some background. So this is a 41-year-old lady with low GCS. She is post-op following an incision and drainage of a breast abscess. She's got a history of hypothyroidism and obviously the breast abscess. She is a little bit hypotensive, maybe you could argue. Her respiratory rate is 9. I will just highlight that to you there. And you can probably already see where this is going. and she's only responsive to pain. So you do your A to E. So when you go and see her, her respiratory rate's now 8, her SATs are 92, chest sounds clear, and you've got an ABG which shows type 2 respiratory failure. Blood pressure is still slightly on the low side, getting slightly lower, and her capillary refill is just slightly long. I'm going to talk about GCS, so I've put TBC, which means it's going to be on the next slide. She's got pinpoint pupils, reduced pupillary reflexes, and her glucose is normal. She's afebrile. So what is everyone thinking here? Great, yeah. So I'll just tell you a tiny bit more. So this lady is 8 hours post-op. She had a general anaesthetic with propofol and remifentanil, so these are both opioid. And she's also on a morphine PCA, which she's been using frequently. And she's had some nausea and vomiting. So like you said, you're all going in the right direction. Someone said morphine, mention of naloxone. I like it. So I've just put a little summary of GCS on here. So this lady has, these are your kind of GCS categories. You've got your eye response, your verbal response, and your motor response. It's probably vaguely useful to have an idea of this, but again, when you're there, you can look it up. So just kind of have it in the back of your mind, but you don't need to memorize, especially the motor one. I never remember. I just look it up. So this lady is only opening her eyes to pain. She's making kind of sounds, but no coherent words, and she localizes to pain. So her GCS is 9 out of 15. So are we worried about her? And what do we think we're worried about? Yeah, great. So we're worried about her because, yep, her GCS is low. She's at risk of losing her airway, and she's got respiratory depression, which is causing low saturations. So what are we going to do? Yeah, we're going to call the med reg, and we're going to do some of the things that you already said. So again, we're going to put her on oxygen, and then someone already mentioned naloxone. So this one, I would say, having done some reading for this, I would say that you can probably give naloxone before the med reg gets there if you're suspecting an opioid overdose. Particularly because it can actually be used diagnostically. So if someone has low GCS and you don't know why, you can give naloxone. If they get better, then you know why. So there's kind of no well, there is a drawback, but if it's something that you're suspecting, the quicker that you can give them that naloxone, the better. And you can do that. You can kind of say to the nurse, can we get some naloxone, then call the med reg and then give it before they come. You don't need them to assess it, and the quicker you can do this, the better. Just a quick note that when you give naloxone, it really rapidly reverses the opioids and it can precipitate withdrawal. So you need to expect pain and confusion and agitation. And also make sure you stop the PCA. Don't let them keep having morphine, because that will just mess your management up. Any questions about that? They should have it as a PRN, but they won't always. And I don't think it would. I don't know. It depends on the seniority of your nurses. If you've got a nurse that can say without a doctor seeing them, oh yeah, this looks like, I don't know. I've seen people with opioid overdoses and they haven't just given naloxone before I got there. So I think not necessarily, but I don't know if they can. I guess they probably can, otherwise it wouldn't be prescribed. I don't know. But it should already be prescribed, but it might not be. So just make sure this is something you're thinking about, even if it's not. I think I might skip the next one because it's quite obvious and it's quite simple. So I'll just whiz through it and I won't ask you any questions about it. It's an 18-year-old. He has had an episode of syncope, felt very anxious and then faint and sick and then collapsed. No convulsions, no kind of signs of seizures, no signs of chest pain. Your diagnosis is going to be vasovagal syncope. I'm going to tell you that now. So just kind of thinking about what your management would be, just to save us some time because the football's on at 8. Does anyone have any ideas what your management might be of if your working diagnosis is vasovagal syncope? Yeah, definitely. So what I would say is you're going to go see him. He's probably fallen, so I would be doing a falls assessment like we talked about before. It's quite a lot easier in a not confused patient because you can ask them if they have any pain, and if they say they haven't got any pain, you can pretty much ascertain that they haven't injured themselves. You will probably ask for an ECG just to rule out arrhythmia. It sounds very typical of a vasovagal, but you don't want to miss something crucial like an arrhythmia causing that. Yes, you would give some fluids for the low blood pressure, and you would just recheck the obs and make sure that everything has normalized in 15 minutes. If everything's normal after 15 minutes, this is another one that you can just kind of hopefully forget about. If you don't get another call, they're probably okay. I've just whizzed through that just in the interest of time. Has anyone got any questions about that one? Great, right. So the next one is oliguria. So you get a call from the nurse. The nurse says, my patient has had a much lower urine output than usual over the last couple of hours. And I'll tell you a little bit about the patient. So this is an 80-year-old man. He was admitted for a transurethral resection of the prostate. He's got a past medical history of BPH and a stroke in 2015. His OBS look pretty stable to me. That's news 0. So you're going to go see him, and when you do go and see him, again, you do your AT. He looks pretty well. His chest is clear, SATs are stable, heart rate's okay, blood pressure's stable, GCS 15, afebrile. You look at his catheter and you can see clots in his catheter. So what are we thinking? Okay, so let's get a little bit more history. So we already know this. He's had a recent urology procedure, and he's got a catheter in situ. So anyone got any thoughts on this? Yeah, great. So working diagnosis, exactly. Yeah, blocked catheter due to blood clots. So it's a false oliguria. So you're kind of giving the impression of a low urine production by the kidneys, but that actually the kidneys are fine. So I think this is a really good example of a patient who, if you look at the title of the slide, you're really worried about them. But if you get a bit of history from the stuff on the left side of the screen on the phone, you're probably quite a lot less worried about them already. And once you've done your ATE, you're probably not worried about them at all. So what are you going to do? Exactly. You're going to flush the catheter. I have never flushed a catheter. But you can ask the nurses to do this. If you haven't done it before, then you can ask for some senior support. Doesn't need to be the med reg, a senior nurse would be fine. So it kind of involves removing the catheter bag and then just putting some saline in, getting it back out again. You can do that 3 times, I think. You're basically just trying to clear any mechanical obstruction in the catheter. If that doesn't work, then you might need to change the catheter, but I would probably check with the registrar before you do that, because sometimes it's one of those classic things of removing something that's in and then you can't get another one back in. So it's just worth discussing with a senior. And continue monitoring the urine output, because you might flush it, get some urine output, and then it clots again. So just make sure that they're still monitoring that. So the last case is delirium. So again, I'll just kind of race through the start. So this is a 61-year-old lady who has come in with leg swelling. She's now got new confusion. She's got past medical history of eczema and rheumatoid arthritis, and her blood pressure is 81/44 and heart rate is 122, and temperature is 38.5, and she's confused, which is what you've had the call about. So are you worried about her? Yeah, me too. So you go and see her, you do your A to E. And when you examine her, you find that she's got a hot, tender, swollen right leg, right calf. She's got reduced urine output, she's got low blood pressure, she's tachycardic, her chest sounds clear, but she has got this new confusion, and we're worried about her. The history is that she was admitted with leg swelling. She's awaiting an ultrasound for a suspected DVT, but today she became more unwell with some drowsiness, and this evening she's become much more confused and is disorientated to time, place, and person. What are you guys thinking at this point? Yeah, so a P is a reasonable differential, but in this situation we've got someone who's febrile and with the kind of picture of a confusion and decline is a bit less likely. So like you said, confusion screen including inflammatory markers is what you're going to want to do. And in this case, you've got the leg, which is kind of directing you towards cellulitis. So I'll just race through this as well, I think, because I'm sure you guys do you know the mnemonic for causes of delirium? I'm sure you do. Yeah, perfect. So I'll just put that up as a reminder. And in this case, we're thinking infective cause. And so what's our working diagnosis here, do you think? If you think about the overall picture. Okay, so my working diagnosis here would be sepsis secondary to cellulitis. And so what are we going to do in this situation? I'm sure you guys have had this one drummed into you since birth. Or maybe everyone's gone to watch the football, I don't know. Yeah, exactly. We're going to do the sepsis 6, and we're going to have done our usual things on the A to E as well. So we're going to kind of overall make sure that we've done all these things. We're going to take blood cultures, lactate, urine output. We're going to give antibiotics, oxygen, and fluids. In this situation, it's probably going to be IV flucloxacillin unless they're pen allergic, because we do have a likely source. If you didn't have a likely source, then you would go more broad spectrum. And absolutely, you're going to be calling the med reg for this patient. You're going to be calling them before you do any of that other stuff. Any questions about that? Perfect. So sorry for speeding through the end there. I just have one kind of final thing that I wanted to go through, and this is just for you to reflect on yourself. But if you now look at this same list but with a bit more detail in your working diagnosis, just have a think about how you would maybe prioritize it differently. So I think my favorite example is the oliguria. I probably would look at that initially and think, oh, this person's really sick. This is, someone hypertensive, AKI. I'm quite worried about them. But actually that little bit of information on the phone that you can get from the nurse to say there are clots in the catheter and they've had a recent urology procedure means that I would review them much later than if I didn't have that information. So maybe at some point, if you just kind of revisit that list and have a think about how that might change your prioritization. That's everything. Thank you for coming. Thank you for being interactive with me. It was really helpful. Does anyone have any questions about that at all? Yeah, please do fill in the feedback form. I'd be really grateful for your feedback. Absolutely fine. Yeah, go for it. I think this varies in different hospitals, but for my hospital, there's a crash team. So as the F1 in the crash team, you will go to arrests and medical emergency calls. They'll also be attended by the outreach team, by the medical registrar, by the anaesthetic team, and everyone will know what they're doing much better than you. And your job will either be to scribe, so just keep time, basically, or you might be asked to attempt IV access. I found them quite leveling experiences, and I've seen very experienced anaesthetic regs miss cannulas, and I've seen F1s bash a green cannula into someone who's really sick. It's much less judgmental than you think. So if you get there and you're supposed to be putting a cannula in and you try and put a cannula in and you can't, no one cares. No one will give it a second thought. Someone else will just put the cannula in. I think they are quite stressful to think about, and they can be quite stressful, but you will always be quite heavily supervised. I would say more so than I expected. And most of the time you'll be sat in the same place as whoever is also going to that crash call. So if you're kind of clerking, you'll be there, the med reg will be there, your bleeps will go off at the same time, and you'll go together. I think it's quite, in my experience anyway, it's quite unusual to be the first one at a crash call for any period of time, really. I've never been kind of spammed. So
just to chip into that, I've found that I think it depends on whether you go to tertiary or DGH hospital. I think sometimes the DGH is you're a bit more likely to end up first. Always just do your A to E. That's the only thing they're actually going to really expect you to do if you get there first, and just start all the things that you've learned about at med school. After that point, if you get there, second, third, etc., just grab a computer or grab the notes, start scribing at the start initially at least. That's a really nice, easy job. You can kind of see how it goes and how it works. And then after you've seen a few, I'm sure you'll feel a bit more comfortable to then start doing more things like IV access, or, if it's an actual cardiac arrest and compressions or these kinds of things. But I mean, I don't know about Jane, but I know from my perspective, I've only done chest compressions once. I've attempted cardiac IV access actually only a handful of times. Largely, I've been doing either the ATE or the scribing, to be honest. But I think it does vary on the hospital.
Yeah, I think I would agree. I'm actually in a DGH, not a teeny tiny one, but yeah, I've done chest compressions once, attempted IV access a few times. I've failed IV access every time except once. No one's ever said anything about it to me afterwards. Basically, like you said, do your basic life support, do your A to E, and beyond that, do what you're told, I would say. Any other questions? If not, shall we leave it there? Oh, there's my cat in the background. Great. I'm going to log off then. Thank you so much for coming, everyone.
Thanks, Jane. Thanks so much.
Thank you. Bye.
Yeah.